These are the data that we get on the HCP graph, which is the sensor data. So what we rely on is an 80% time in range, or at least 70% time in range, which is 70 to 180 for non-pregnant, and in pregnant 70 to 140. The estimated A1C should be less than 7%, which is GMI, and glucose variability should be less than 35%. So there should not be, although it is HbA1c is, or A1C is 7, it should not be variable. That is also what we see. I'm just going to show you what we see. This is from the Freestyle Libre. This is what we see on our phone. The first one is an ambulatory glucose profile. So this patient has clear excursions after breakfast and after dinner. So that's where we have to target our therapy. Then they can also see what is the time in range. They can see how many lows have happened, what is the average glucose per every hour. Most of our physicians, we see this daily graph. That gives us it's like an ECG. You don't have to know how much sugar is there. You have a picture, you know what's the sugar, you can easily adjust. So I mainly look at the daily graphs, and based on that we can adjust. A1C, it will give an estimated A1C. So this is what so what I see, the target range, what is the glucose, how much, whether the time in range is good or not, whether there's any low sugars or not. And I also have a cumulative view of their daily graphs and everyday daily graphs also. So these are some of my old patients that we have initially had very high sugars. We've changed the insulin course, and then over time, in 2 weeks, generally 2 to 4 weeks, we get a very good control with sensors which you're not able to do with normal SMBG readings. This is the daily log if you want to go into more detail about these patients. And this is same in every platform, in SinoCare, in GlucoRx, in everybody gives you this HCP software now where you can use this. So coming to insulin pumps. Any questions about sensors? Okay. So we'll go to insulin pumps now. Dr. Kaisar Junaidi, just give a brief demonstration of what a pump looks like, who we use it on. First of all, let's use how we apply the pumps in patients.
Thank you so much, sir.
Thank you. Thank you.
My flight schedule is there.
Right.
And thank you, audience, for having any questions. Please do come back to Kalyan, sir. He is there, and he will having complete about IKLI.
Thank you. Bye. Bye.
Thanks once again to everyone.
Do you want to stand up on this chair?
No, I think I'm fine. The first thing is, what is the problem statement? Why do we even need an insulin pump? Right? It is generally for people who are type 1 diabetes.
You can take this mic.
Thank you, sir. It is for people with type 1 diabetes, and these are the typical people on basal bolus therapy, requiring 4 times injectable, and they have a glucose variability.
Public demand. We have to go on stage. Come.
Yeah, so maybe you guys can sit, please. I won't take more than 10 minutes. Yeah, so it is for these people who require insulin 4 times a day, right? And skipping one dose is going to be difficult, or taking suboptimal doses, because type 1 diabetes it has a lot of inter-day and intra-day variability. Don't you agree? And therefore, it requires constant monitoring. If you look at a type 1 diabetes child's mother, constantly she'll be engaged with the child, checking the sugars, giving insulin, controlling the cravings of the child, and all of that. To exactly address this problem, we need an insulin pump, something that is going to take care of insulin delivery like the physiology does. Second, check sugars automatically without the child having to prick. So, and if the greatest thing that has happened in the domain of diabetes was CGM, which sir was talking about. Only because of CGM, insulin delivery has been made possible. Automation in insulin delivery is made possible. And now imagine, this is a pump, a very small device. When it was first invented back decades ago, it was like a backpack. And today you have a pump that can be just in your pocket. And this insulin pump has a reservoir. This is the reservoir. It can hold up to 300 units of insulin. From the cartridge, say Novo Rapid, you take that insulin and put it in this. This reservoir is put in the pump and an IV set is connected to it. This IV set is connected to a cannula that is put on the patient's stomach. Right? And there is a sensor on the hand. This sensor transmits glucose to the pump. Every 5 minutes, yeah, this is the sensor. This is a transmitter. This transmitter costs 70,000 rupees, by the way.
So you can take out the transmitter from the pump and reattach it. It's like a battery chargeable transmitter. It's sticky. It comes out.
Need help?
The gum on it, not like that. So anyway, this transmitter comes out. You can recharge it and go back on it. This transmitter then takes signal from the
sensor.
Sends the signal back to the pump. The pump then decides how much insulin to deliver.
Yeah.
So all of this is not expensive. The algorithm which decides how much insulin to give, that is the costliest part.
Because safety is most important here. You know, I think we are in a centrally air conditioned place. There's a temperature that is set to it. Okay. If the temperature drops, it tries to bring it up. If it goes up, it tries to bring it down. And this is exactly what the pump is doing. There's something called as a smart guard. When you put the pump on an automation, the insulin is delivered automatically, and it has now the ability to stop the insulin delivery before low. It suspends the pump before low. Previously, it used to suspend at low. So patient has already had a hypo, then it stops the insulin delivery. Now it can anticipate that this patient is going to have a hypoglycemic spell, and maybe 20 minutes advance, it can stop. I hope in CGM you are aware, there are some arrows with each number. Okay, say it is showing 136 milligram per deciliter as your current sugar level. It has an arrow mark along with that number. If the arrow is pointing towards your right, it is almost stable, no significant change in insulin, and no significant change in sugar levels. If it is perpendicularly up, straight up, then it is increasing more than 2 milligram per minute. Right? So in the next 10 minutes, it's going to increase by 20 milligram. If it is slant, northeast, if it is like this, then it is 1 milligram per minute rise. This way it is less than 1 milligram drop. This is 2 milligram drop. So now the pump now can anticipate if the sugar is dropping at a rate, say more than 2 milligram per minute, then in the next 15 minutes, the patient's sugar is 100 now. In the next 15 minutes, this can go to below 70, which is a hypo, and it suspends the delivery right now. That's number one.
Yeah, I'll come to those. I'm just going to, so I'll come to the algorithm in a bit. Just wanted to show what is the nitty-gritty of this. So this sensor has to be changed every 7 days. We are going to upgrade, the Medtronic is going to upgrade to Abbott Instinct next year, which is going to be every 14 days. The cannula is, now we are changing it every 3 days. It's going to be every 7 days. So the number of injections that the patient uses, imagine a child using 4 injections per day. He only has to use 1 injection in the future, maybe once every 2 weeks. That's all it is. So it's a huge advantage. And it's not just about what this shows. It's about what Dr. Kaiser was saying, how the auto-basal features. So the 3 things about sensors is, one is auto-basal. That means we cannot set a basal to a child or an adult, whatever basal it is, 10, 12 units, it's not enough. On one day, it may be high on one day, we have that fluctuation. So to mimic that artificial pancreas thing, the auto-basal, if the sugar is going down, it reduces their insulin delivery rate. If the sugar is going up, it increases your insulin delivery rate. The second feature is about auto-correction. These blue lines that you're seeing, if you see the sugar After the maximum basal rate has been hit, if the sugar is still high, the pump then delivers auto corrections. You don't have to manually give auto corrections. That is the second feature. Third feature is about suspend before low, not suspend on low. If you see the pink graphs in the bottom are where the insulin is being delivered. If you see the gaps there, the pump has expected that the sugar is actually going down, and once it is anticipating that it will reach a hypo, it will automatically stop sugars, automatically stop the insulin delivery. What happens after that? Our body has counter-regulatory responses. It will bring it out of the hypoglycemia. Yeah. So this is what we actually look at when we see the patient. I see how much insulin is being delivered, what is the coefficient of variation, how much bolus they have given. I caught a lot of cheaters on this as well, where they don't take the insulin pumps. 3 settings we have to put for us initially. As a doctor, I only need to put settings once before I start the pump, which is what is the insulin to carb ratio, what is the glucose target. Glucose target is basically like temperature. If I want the AC temperature to be 22, the AC will work very fast. If I want a little slow, I can put it, if I'm happy, I'll put it on 24. Like that, if you want a very tight control, you can put 100 or you can put 110 or 120. Some people who are low prone to hypoglycemias, we put 120. Active insulin time is basically just to, I'll not cover that in a bit. So we see a lot of these graphs on the report. What is the total daily dose? How much auto correction is going? If there's a lot of auto correction, we increase the bolus. The only thing the patient has to take is he has to enter the carbs, a number of carbs that he's taking in. Approximately, doesn't have to carb count exactly, roughly amount of carbs that he puts. And then we can find out how much the bolus is going on, what is the correction, how much correction is going on, where is the patient spiking. All of this data, once you are aware, you will, we'll do separate workshops where I detail how to read this data as well. And once that is done, the patient is done. I mean, a lot of my pump patients are actually not coming to follow up as well, because the pump takes care of everything. My role is just to tell the pump how much insulin to give initially. After that, it is all up to the pump. So with the interest of time, I'm going to stop. Any questions about the 780G?
So just like to add one thing, sir. So sir mentioned about auto correction. No. So it's like you have said a patient is requiring 24 units of Lantus insulin. So how much is he taking every hour? 1 unit per hour. So you have said 20% you have reduced the dose. You have set it at 0.8 units per hour. Isme, you also mentioned what is the maximum basal that can be given. If the sugars are, going haywire, if they are increasing, what is the maximum that you can go? So this pump can go from 0.8 to say 1.6. It is going at its maximum now. And despite that, post-meal, the patient's sugar is going beyond 240. Now it gives an auto correction. So small, 0.5 unit, 0.3 unit, 1 unit, it gives auto corrections and tries to bring the sugar down. So therefore, the time in range, the glycemic variability reduces, the time in range improves, risk of hypoglycemia is lower, and overall the outcomes also are better.
Thank you. So any further questions on insulin pump?
Any malfunction is expected anytime? With the Medtronics, not yet. It is the only approved pump.
You can expect some technical, the sensors may fail, yes. The cannulas may get blocked. These are things that we see. Very small, which can be easily fixed. 6 lakhs.
How to detect it, sir?
Detect what?
Malfunctioning is there.
The pump has a lot of alarms. It will give you alarm at every stage. Yes, the Medtronic support is very good. 24/7 they help. And we always tell the patient to have a basal insulin backup just in case the pump fails.
Loopholes will be corrected by the pump itself.
What?
The loopholes means
Loopholes. It won't be corrected, it will be detected. So it says pump is blocked or sensor data not detected. So those alarms will come and the patient has to take action about that.
Transmitter battery low. This is an alarm. So you need to charge the transmitter. Or check the IV cannula. So if it is beyond 5 days, you had to change it 3 days. If it is beyond 5 days, then you need to correct it.
GDM. Yeah, a lot of some of my colleagues are using it on a rental basis in CGM. You know, you can use the pump as, because 6 lakhs for just that pregnancy, nobody will do that. The delivery cost will be less than that. You can use, sometimes rental basis we are using, and it's very good, and the outcomes are good.
Is valuable also in DK also, sir?
DK, no sir, not DK. No, DK,
Not in acute emergency like
Ah.
DK, hyperostomal or
after that, once the patient is out of the emergency, yes, we can start.
stable can be.
Yes.
Patient will be able to manage it himself, or
Yes.
does it require any customer care?
Initially, sometimes, initially for all these alarms, what to do and all that. After that, children do it better than me. My children, my young patients come and tell me about some features which I didn't know.
Cost of blood glucose monitoring,
The total cost is 6 lakhs initially.
blood glucose monitoring.
So the sensor cost and the cannula cost will be 20,000 per month.
Consumables.
Consumables we call it.
24 hours glucose monitoring,
That is 4,000 per week. It will be 4 weeks, so 16,000 plus consumables around 4,000. So 20,000 per month is their expense. Apart from insulin. They will not require basal insulin. It's only short acting, only bolus we use. Last question.
What is the CV percent for this?
What is the
CV percent. CV.
coefficient of variation? For what?
This machine.
You mean, see, the sensor has something called MAD ratio, which is coefficient of variation is what we see in our glycemic index for the patients. The MAD ratio is what is the difference between the actual glucose and the interstitial glucose. That is less than 8%, which is very good. A lot of new sensors are very good. Even Abbott Instinct is coming for them. That's even more sensitive.
For the Guardian 4 sensor that is connected to the insulin pump Medtronic, you have the ability to calibrate the sensor. So you check on AccuCheck Guide. On AccuCheck Guide, you check sugars, and you put it in the sensor, in the pump, and then now these two readings will start matching.
Right. Thank you. Thank you. So we'll move on to the next workshops. We have Dr. Rama Rao who will demonstrate what is the importance of diabetic foot, how we manage diabetic foots, and Dr. Siddharth who will teach you on how thyroid ultrasound is done. So if you can split into groups or go at once, we'll leave it up to you. Sir? Over to you. Thank you. Thank you, Doctor.
Thank you very much. Thanks to Kalyan sir for the opportunity.